First, let's start with the definition of GERD. So what do we understand by the term GERD or gastroesophageal reflux disease? What exactly it is?
So as the name itself tells that there is a reflux of the contents from the gastric section to the esophageal section. Normally, the reflux do occur in a normal individual also. This is called just gastroesophageal reflux, but this is not a disease per se. All the refluxes are not pathological. The reflux is a physiological process. It occurs in all individuals. It usually does not produce any symptoms to the patient. It does not produce any problem to the esophagus for its mucosa or anything. And it usually occurs in the immediate postprandial period, and it never occurs in the night period. So this is called a physiological gastroesophageal reflux. The main thing that defines the physiologicality of this particular process is it does not produce any symptoms. Whereas it is called disease when it produces symptoms or when it produces some anatomical damage or pathology to the lower end of the esophagus due to the reflux contents. So this becomes a disease, and this becomes an important for the medical aspect.
So you mean to say any pathological reflux? There's a difference, my dear friends, difference between regurgitation and reflux. Okay, although it's used synonymously, we have to keep this in mind. Here, what happens is reflux of the pathological reflux of the gastric contents into the lower esophagus or into the esophagus. Okay, that's precisely defined as gastroesophageal reflux disease. So that's about the definition of it. And what are the common causes or etiology? What are the various anatomical factors, physiological factors, and other associated factors which culminate in causing this GERD? So can you please elaborate on this, Dr. Raj?
Yeah, definitely. As I told you, that gastroesophageal reflux is a frequent physiological process, but it becomes pathology when the normal defense mechanisms alters in the human body. So we know that whenever we study the physiology, the basic concept in the maintaining healthy state of any body part is having a homeostasis. So usually the body is being exposed to the constant stress. It will be any particular point of body. So similarly, the esophagus is being constantly exposed to the stress, that is the reflux of the gastric contents, which is highly acidic in nature. We know that only the stomach mucosa or the gastric mucosa is being destined to deal with this heavy load of an acid, whereas it is proximally the esophagus and distally the intestines, they're not ready to deal with this heavy acidity of this content. So we body naturally have this physiological mechanisms to manage this. This is called protective mechanisms for this. There are mainly three important mechanisms involving this protection. One is the anti-reflux barrier, that means constituted by the lower esophageal sphincter. So the lower esophageal sphincter, along with the lower part of this esophagus, along with the anatomical surrounding structures, be it the diaphragmatic crura, mainly the right crus of diaphragm, or the phrenoesophageal ligament you might have heard, and the gastric fundus. So all this constitute the lower part of esophagus. This becomes an anti-reflux barrier. So this is being under a constant state of a contraction to prevent the regurgitation of these acidic contents of the stomach to the esophagus. So this lower end of esophagus relaxes only when we swallow. So this swallow-induced relaxation of this lower end of esophagus is being abnormal in case of GERD. And we know that this is in a constant state of a contraction. Whenever this contraction is defective, then the regurgitation becomes pathological. And there are many other anti-reflux barriers also, like we have an natural esophageal peristalsis. So whatever the gastric contents which regurgitate into the esophagus again gets moved back into the stomach content by the natural peristaltic movements of the esophagus. So whenever the peristalsis of this is defective due to any other disorder of the esophagus, be it an achalasia, be it an other motility disorders of the esophagus, are definitely responsible for this. And again, the esophageal do have some amount of secretory glands in their mucosa which secrete some amount of the the bicarbonate secretion along with the saliva, which has been weakly basic, which tends to neutralize when we swallow this whatever the minimal amount of acidic secretions which are being regurgitated. So whenever the patient's salivation is being affected, be it a scleroderma, be it a smokers, where the saliva content is very low, and B, it is xerostomia, where the patient's saliva output is very low. So these patients are not ready to neutralize whatever the minimal amount of acid which is being regurgitated into the distal mucosa. Along with, there is a definite amount of the tissue tolerance of the esophagus. If you see the distal end of the esophagus, it has got its inherent tissue tolerance because of the cells which are closely adherent. The epithelial cells are very closely adherent with the in between cell what you call attachments, be it a cadhesin, adhesins. So these will definitely prevent the cell denaturation and etc. Whenever this is been defective, the esophageal disease tends to occur, be it erosive esophagitis, be progressing into the Barrett's esophagus, finally progressing into the adenocarcinoma, which is what the ultimate issue of us in preventing all this GERD is being there. So that's why the physiological process is very, very important to understand, to identify the disease aspects and the treatment aspects.
What is the role of anatomical defects? Like we say, it's more common in obese patients and those with lesser length of intra-abdominal part of the esophagus and other things. What is the role of
this? We know that naturally there is a reflux of gastric contents from the stomach into the esophagus. So the obesity causes this increase in the severity by two mechanisms. One, the obesity per se increases the intra-abdominal pressure, where the tendency to reflux increases, and other, the obesity extremely, the patients who are having central adiposity, they have got a lesser tone of this lower esophageal sphincter due to the reduced part of this intra-abdominal part of the lower esophageal sphincter. So that is what predisposes them to have a dysfunction in the lower esophageal sphincter. So this will ultimately leading them to increase the regurgitation events and the regurgitation amount, and increasing the possibility of erosive esophagitis in these particular patients. The obesity is a major risk factor.
So these are the risk factors, like anatomical and various physiological. Also add on to this in diabetics, this diabetic gastroparesis. This also can cause this thing. And if you look at the other risk factors like smoking and alcohol consumptions, excessive fatty diet and spicy foods, and other like caffeine, tea, and chocolates. All this can cause increased risk of GERD, they say. I feel it's not exactly it does it by decreasing the LES sphincter tone. Instead, it causes the irritation of the same. Irritation of
the alcohol itself is a direct toxic to the mucosa. Alcohol being the direct toxic to the mucosa also reduces the gastric emptying. And along with the alcohol, it is the congeners which are used along with the alcohol which have been directly toxic to the mucosa and also reducing the gastric delaying. So ultimately increasing the proximal pressure and causing the increase in reflux events, which are definitely responsible. But as far as the particular amount of our type of food is concerned, the spicy foods or the citrus foods and the chocolates have been particularly depicted in increasing the severity of this regurgitation events in a particular set of patients.
So, okay, these are the risk factors. And what exactly happens in GERD? What is the pathophysiology? What is the mechanism when there is a distension of the abdomen, the stomach, fundus of the stomach? So this brings down the esophageal mucosa and that exposes it for the gastric reflux or the acidity. What really happens?
There is actually a concept called acid pocket in case of the GERD. What happens? The normal pH of the gastric mucosa, you see, it is usually less than 2 due to the hydrochloric acid which is there in this. So whenever a person consumes the food, so this acidity gets buffered by the food content. So this been definitely occurring in the distal part of the stomach, especially the body and the antrum of the stomach. Whereas the gastric fundus, there remains an area where this gastric mucosa remains unbuffered with the food. So this particular acid pocket becomes a probable area from which it becomes very easy to have a very highly acidic secretions to go into the distal mucosa and causing the mucosal damage. Along with this, many of the patients may have a coexisting hiatal hernia, in which the proximal part of the gastric fundus is been herniated into the thoracic compartment by crossing the diaphragm. So these patients are particularly exposed to have reflux symptoms, but it is not a must that all hiatus patients may not have GERD and all GERD may not have hiatus, but the hiatus definitely increases the possibility of having them a regurgitation in those patients.
And one more misconception what most of us have is, does H. pylori causes this GERD?
No. This is rather than a misconception. This is the lacking of the health awareness. Even before my finishing second year MD, I had not read GERD at all. So after entering my MD, when I read Schlesinger GERD chapter first time, I was actually shocked. There was a tremendous amount of knowledge which is there in that particular chapter, and the amount of knowledge I was lacking before studying that. See, the H. pylori, as I told you in the last class, causes two types of gastritis. One is a distal, that is antral predominant gastritis, where there is an hyperacidity and a predominant formation of an ulceration. And there is a proximal, that is a body, a corpus predominant gastritis, where there is an atrophic gastritis. So there is in fact achlorhydria. So this achlorhydria, when the gastric acidity itself is low, it cannot cause the GERD. Yeah, but the antral predominant gastritis can definitely cause the GERD. But in case of corpus predominant H. pylori gastritis, the GERD is not at all common, and GERD per se is not at all implicated as a causative organism in direct association with the GERD. In fact, GERD testing is not definitely necessary for all GERD patients when we go through the endoscopy.
So how do they present with? How do the patients present to you in the OPD? What are the common symptoms?
Yeah, the symptomatology is very important here. The one very important symptom of the gastroesophageal reflux is the heartburn and the regurgitation of the actual content. So heartburn is a burning sensation which is been arising from the stomach or the epigastrium, which radiates to the upper part. It may radiate to the throat, it may radiate to the neck, it may radiate sometimes to the arm on back also. Many of the times it tends to mimic with the angina. Many of the times the people tend to get treated in the line of an acute coronary syndrome, whereas in fact it is a GERD which is causing the heartburn. And it is the very predominant symptom of the patients of the GERD. And if the patient has a heartburn, which becomes a very specific symptom of the GERD, whereas if the patient does not have heartburn, it is not a ruling out mechanism of the GERD. Many of the patients of GERD may not have heartburn, but 50 to 60% patients of the GERD do have heartburn. And this heartburn becomes significant, or it becomes GERD only when the episodes are more than 2 per week. Otherwise, it becomes non-erosive or like non-significant gastroesophageal reflux. Only when the reflux episodes are more than 2, then we used to label it, or we tend to label it as GERD. So, and this particular symptom increases on sleeping, or increases on standing or stooping forward. This is because this is a very important clinical aspect which usually differentiates between the coronary aspect and the GERD aspect.
So mainly that the retrosternal burning sensation, or the pyrosis it's called. And in our surgery books, we also read that they will have epigastric pain, which may radiate to the back. And thirdly, they'll have any features suggest of any regurgitation of contents, acidic contents into the throat. Okay, so this is the typical triad of symptoms. That is retrosternal pain, burning sensation, or the heartburn, or pyrosis, what we usually call. Second thing is the epigastric pain. Thirdly, they'll have features of regurgitation. So there is a lot of differential diagnosis around this. We'll discuss.
And there are other symptoms also, other rare symptoms also, like patients can have dysphagia. If the patient has some ulcers, they can have a odynophagia. Sometimes the patient have the weight loss as a significant symptom. Weight loss with a preserved appetite. Usually we need to think of a GERD, because appetite is definitely not been affected, and a loss of appetite in a patient of GERD actually makes us to take towards the endoscopy to rule out other malignancies. Yeah, and there is a typical symptom called globus sensation.
weight loss is more of a feature of achalacecardia than
Yeah,
GERD.
GRD, yeah, definitely.
So that's how we
GRD
mainly
usually
distinguish
perceive.
between achalacecardia and the GERD. They'll
Yeah,
have
another thing which you can differentiate between the esophageal spasm pain and the heartburn due to GERD and the acute coronary syndrome is to response to the nitrates. The GERD never responds to the nitrate, and the esophageal spasm do respond to the nitrates, but the time taken is very long. It usually 5 to 6 minutes. Whereas in case of an unstable angina, the response to the sorbitol is very rapid. Like within less 2 to 3 minutes, the patient relieves pain. So this is another clinical thing which we use for differentiate between all these three
and
things.
when the patients comes to us and tells that they'll have epigastric pain or this retrosternum pain, this nausea or dyspepsia or dysphagia,
Yeah.
when they complain of this, we'll ask some certain questions like whether it is more during night while sleeping in the supine position, whether it's more. We ask them first question. They say yes, especially after fatty meals or some spicy food. This is more aggravated, they say. So this is again more in favor of GERD, and like already Dr. Raj mentioned, stooping forward. If these symptoms aggravates, then also it's again more in favor of GERD. GERD is more of a clinical diagnosis and very common these days. Although we have got very advanced
Yeah, it is a very common
medical
disease
and
of
surgical
human
treatment.
mankind.
This
Yeah.
one of the
Very common.
most common benign maybe MCQ, which is the most common benign esophageal condition, that is the GERD. Okay.
Yeah, it
Uh,
can definitely.
yeah.
And
So
there
what
are
are
other
the
non-esophageal manifestations also of this disease.
okay?
Many of the times patient may not present with any GI symptom at all. Like sometimes patient can have nocturnal wheezing, which may be due to the
Yeah.
aspiration of
Asthma.
the
Yeah.
nocturnal contents. And patients are particularly prone for
Cough.
asthma, especially the difficult to treat asthma. There is a particular type of asthma we use the terminology that is difficult to treat asthma, where the patients are not being controlled even after the inhaled corticosteroids and even after oral steroids. Patient might be having a nocturnal micro aspirations due to the GERD, which needs to be assessed. Although all the asthma patient need not be put on the PPI, but definitely GERD has to be considered. And even in the patients of recurrent pulmonary infections, where the cause is
Yeah.
definitely not being ruled out, especially old age people who are bedridden, and patients of some unexplained ILDs, especially where the low predominant ILDs are there, needs to be assessed. And chronic laryngitis, the patient might have the laryngitis, especially the interarytenoid spaces and the posterior part of the larynx. There is a typical pattern of this reflux laryngitis, which has been seen by the ENT specialists. So these are definitely needs to be assessed, where the patients may not definitely have any symptoms pertaining to the GI tract. The symptoms can be entirely extraesophageal. So this particular disease needs a high suspicion in diagnosing the GERD.
Yeah. And what are the common conditions we need to rule out, Dr. Raj, at this scenario?
Yeah,
Like one we
one
already
of the
mentioned, the achalacecardia.
very common and very interesting diseases are these functional dyspepsias and
Okay.
the esophageal motility disorders we need to rule out.
Disorders
We need to
and gastritis.
gastritis, the acute gastritis. It can be the
Peptic
peptic
ulcer disease.
ulcer disease. It can be the gallstones sometimes,
Gallstones.
or
How do
it
we
can be.
differentiate one by one? We'll discuss. Any one characteristic features do we have to differentiate between these two? For example, between peptic ulcer disease and the GERD.
Yeah, the peptic ulcer, as we know, the predominant symptom is the epigastric pain, especially in a patient who is exposed to the NSAIDs or the old age people or the patient who has been proven to have a H. pylori, where they have a particular pattern of this pain, where the
Intermittency.
pain usually occurs after 6 to 8 hours of the food. When the stomach is empty, there's a tendency to have a increased uh, pain. And along with this, the patient may have the symptoms of the GI bleed, where the patient can have the melena or the hematemesis due to the bleeding of the ulcer base. And the weight loss is also the symptom of peptic ulcer disease rather than the GERD. And the very common disease and very unaddressed disease is the functional dyspepsia. Many of the people think that GERD and functional dyspepsia are same, but they are entirely two different diseases. Functional dyspepsia, as its name suggests, it's a functional disease. There is no organic abnormality in the patient going on. So functional dyspepsia, there are multiple types. There is epigastric pain syndrome, there is postprandial distress syndrome. There are many of the types we'll be presenting with. And the gallstones, patient can
typically have
the
a
pain.
upper abdominal pain. They'll have that colicky pain. They will have, and periodic, and they can also have the features of cholecystitis. Okay, and they'll and they more than the regurgitation and all, they will have mainly features of dyspepsia, and that nausea or vomiting they can have. That's about pancreatitis.
And some rare
pancreatitis.
Pancreatitis presents, as we know, that acute pancreatitis presents with a very sudden, severe pain in the epigastrium, which radiates as if there is something tearing through the, which is going to the back, and the patient are usually very sick looking, and it is a very acute symptom rather than the recurrent symptoms. It is an acute symptom where the patient present with an acute pancreatitis. In case of chronic pancreatitis, the patient have a history of being diagnosed to have acute pancreatitis presenting with a recurrent history of pain, or the patient may have a steatorrhea along with this. Patient may have a severe weight loss, a recently diagnosed diabetic after the first episode of his severe abdominal pain, progressing into the need of the insulins. These are factors which goes or takes towards the pancreas as the etiology of the epigastric pain.
So now there are some overlapping symptoms between few of the conditions. So how do you go about in evaluating the patients? How do you confirm or diagnosis of GERD?
Yeah, actually, if you say a GERD per se is a clinical diagnosis, does not need any investigation. As I told you, if the patient has more than 2 episodes of heartburn per week, the patient needs to be directly taken into the treatment, be it a lifestyle modification or an acid suppressive therapy. The investigation is mainly done to know the extent of damage to the esophagus or to rule out the other diseases which we just discussed. We were thinking of GERD, but actually patient is having achalasia, or if the patient is having peptic ulcer. So for these particular kinds of diseases, or to diagnose the complications, the investigation we need to go ahead. Otherwise, per se, GERD is entirely a clinical diagnosis. The patient of more than 2 episodes of heartburn needs to be directly taken to the treatment, and only when the patient does not have any typical symptoms. And we have other diseases to rule out. Like if we are confused between the cardiac cause of chest pain and the GERD, or if the patient has dysphagia as a symptom of this, odynophagia, all these symptoms, as I told you, the atypical symptoms makes us to go take towards the part of investigations.
Okay. What are the investigations do commonly perform for these?
The investigation usually takes towards in diagnosing the GERD. The gold standard, as we know, it is the pH monitoring, the ambulatory pH monitoring of the distal end of the stomach. But before going to this particular investigation, as I told you, the investigations are mainly done to rule out the other conditions. So the upper GI endoscopy, as I told you, it is being considered as the investigation only when we have got some other differential diagnosis to rule out and risk factors to have a malignancy or the Barrett's esophagus. For example, if the main important risk factor for Barrett's esophagus up to 6 years, yes, the patient definitely demands an upper GI endoscopy along with the addition of other factors like this, the first degree history of esophageal carcinoma, if the patient is a smoker, if the patient has weight loss, if the patient has the more than 10 years duration of the GERD, and patient has not responded to the standard course of the treatment, this will definitely makes us taking towards the upper GI endoscopy. And the evidence of any malignancy, if the patient have any undiagnosed iron deficiency anemia, if the patient have the evidence of a hematemesis or a melena, or if the patient has weight loss, and the dysphagia, odynophagia obviously takes us towards diagnosing upper GI endoscopy. And the upper GI endoscopy per se, if it is normal, it does not mean that the GERD has been ruled out. Upper GI endoscopy can be completely normal in a patient with a full-fledged GERD, because sometimes the distal end of the esophagus may not have any gross changes. Also, sometimes it may need to take a biopsy from the distal end of the esophagus to actually diagnose the microscopic esophagitis, which has been seen on the histology slides only.
So that is about role of endoscopy, and any anatomical visualization in the form of barium or anything.
Yeah, the barium swallow can identify the hiatus hernia, the presence of hiatus hernia, etc. And it can also identify the erosions, if at all they are big, and it can even identify some ulcers which in the distal end of the esophagus. But GERD, again, as I told you, is not a ideal choice for the to diagnose GERD as per condition. But
ideally, we get manometry done to rule out other motility disorders, and then this 24-hour pH monitoring to know the severity of the reflux. That's the gold standard. That's considered gold standard at 24-hour.
It is definitely a gold standard. Initially,
not usually done.
It is very unusually done. I think nowadays they have got
only before surgeries we get it done.
Yeah, before fundoplication, it is definitely necessary to have a 24-hour pH monitoring, because we are thinking of GERD, but it is not GERD, then it becomes a very big problem. And there is nowadays they have got a recent advances of having a capsule capsule pH monitoring. Like they have got one capsule which has been endoscopically inserted through the distal end of the esophagus, and it can have a computerized connection or the Bluetooth connection to monitor the acidic events or the reflux events, we know. And earlier, I think 5 to 6 years back, we did not have any criteria to define what is there in the 24-hour pH monitoring. But nowadays, we have got a particular set of criteria after the Lyon hypothesis, which has been done after 2019. The acid total duration of the acid exposure time should be more than 6% to definitely diagnose it as GERD. If it is less than 4%, then it is GERD is ruled out. 4 to 6%, then it's a borderline. Then we need to rule out other diseases also. And nowadays we can have a symptom-based correlation with the this pH monitoring also. Patient needs to write these symptoms. Whenever he has a heartburn, then the pH is correlated with the distal end of the esophagus also.
Not as a prerequisite before doing this pH monitoring test.
The PPI has to be stopped for at least 2 weeks, but it is not been necessary nowadays, because the main thing which was not detected in the 24-hour pH monitoring was the non-acidic reflux. The pH monitoring only depicts the pH. If the pH is more than 6, it does not pick it as normal thing. Whereas the patient who is on PPI may not have the acidic reflux. The patient on PPI may have a non-acidic reflux, which actually contains pepsin. So this pepsin is a proteolytic hormone. This behaves as if it is an acid only. So it definitely denatures the protein. So it is important to measure the non-acidic reflexes also. Yeah, but if you are going ahead with the 24-hour pH monitoring, you need to stop the PPI for at least 2 to 4 weeks prior to that.
Do you use any, in your practice, do you use any scoring systems or anything to assess the severity or anything?
Yeah, we use the Los Angeles scoring to actually rule out the esophagitis, and to grade the esophagitis. We have got 4 gradings, in which the severe grade is a circumferential erosion, either at the more than 270 degree or 360 degree erosion if it is there. Then if it is less than 270 degree, then it becomes grade C. If it is less than 5 mm, it becomes grade A. If it is more than 5 mm, it becomes grade B. It is not a thing scope for this undergraduate discussion. Yeah, but Los Angeles classification is being used for the erosive esophagitis classification, where the class C and D will definitely tells that it is an erosive gastritis. Class A and B, it is a borderline, need to make a histological diagnosis, and also may demand a 24-hour pH monitoring also.
What about D-Mister scorings?
We use only Los Angeles scoring. I haven't heard of this particular scoring. Maybe using in surgical sector.
So okay. Once the diagnosis of the GERD is done by 24-hour pH monitoring or by ruling out other possibilities and uncomplicated. Let's say now patient is having uncomplicated GERD. So how do we treat?
Yeah, again, as I told you, it is an uncomplicated GERD. The complications are not there. Then we need to decide whether it is a mild disease or a severe disease. Mild disease means the symptoms are not severe. The patient does not have any erosion on the esophagus, or the patient does not, if at all, the patient endoscopy has been done. it is not necessary for the endoscopy to be done, as I told you. If at all endoscopy is being done, if there is an erosion, if the patient has mild symptoms or if the patient has intermittent symptoms, then we follow a particular therapy called step-up therapy, where we sequentially increase the severity of the treatment. First, we initially start with the only lifestyle and the diet modification. Then we go for the medication treatments. Then we, if patient not responding, then the severity of this treatment increases. Maybe patient may be needing for endoscopic treatment or patient may need for a surgical treatment. Whereas if the patient has the severe symptoms or if the patient has a abnormality of the upper G endoscopy, for example, if you've done an endoscopy, it has shown some amount of erosion, some amount, especially Los Angeles C and D, we follow a step-down therapy. First, we give a good therapy, like first we give a medical treatment, we give a acid suppression therapy for a full amount of time, then we follow step-down therapy, progressing into the lifestyle modification. Whereas the lifestyle modification and diet modifications will be there for the lifelong. These are the first and the foremost treatment approaches which has to be addressed to the patient. Without lifestyle modification, the success rate becomes very, very low. The main lifestyle modifications are very, very important. The proven things are actually only two. One is weight loss, another one is the head and elevation. Whereas there are other lifestyle modification also, like if the patient need not lie after consuming the food, the amount of food has to be important, the content of food has to be important, the patient should not consume any citrus food, fatty amounts, patient should not consume alcohol, patient should avoid smoking, then the amount of the food should be very small, it should be frequent and small meals needs to be consumed, and patient should not consume anything at least 2 to 3 hours before sleeping, especially in the night time. So these are the other lifestyle modifications which have been definitely advised, whereas the proven things, the statistically proven things are only two. First and foremost thing is the head and elevation, which is a very, very important, because we need to definitely address the nocturnal symptoms, because it is a very difficult to address. Even if the patient is on the acid suppression therapy, the nocturnal acid excursions are very, very common in case of GERD. So the head and elevation is very, very important. And the weight loss. The weight loss needs to be addressed along with the diet modification. The patient should not have a severe weight loss. It needs to be tapered with the individual aspect. At least 10% of the weight loss is definitely necessary to achieve the symptoms, and it needs to be maintained throughout the life. And coming to the medical treatment, there are many but over-the-counter medicines which are available for the heartburn. Many of the patient before coming to the hospital might have taken this over-the-counter treatments, especially the antacids. The antacid syrups are very commonly used, even advertised in the markets, advertised in the television and the social media also. So these are the over-the-counter drugs which are available, and other over-the-counter drugs which are being available are the PPIs and the H2 receptor antagonists in the low dose are definitely available as the over-the-counter, not Schedule H. Especially if you take Omeprazole 20 mg, it is definitely available as an over-the-counter. Patient need not have any prescription for the Omeprazole 20 mg tablet. Whereas if you have a 40 mg prescription, only 40 mg is given only for a prescription. 20 mg is not given for a prescription. So 20 mg is being available for over-the-counter drugs. So many of the patient comes and tell me that I have already taken Omes 20. It is not relieved the symptoms. So the over-the-counter medicines are available, and many special kind of over-the-counter medicines are also available. Like there is particular preparation called Gaviscon, which contains, along with the antacids, it has sodium alginate. So this alginate is a chewing gum like thing. So it floats in the gastric mucosa and the esophageal mucosa to prevent the mucosal damage. So this is one over-the-counter medical therapy which has proven the efficacy in management. Whereas all the other over-the-counter drugs are only for the symptomatic relief. They does not produce any improvement in the erosions which are present in the esophagus. If you come to the medical management, there are only mainly three class of drugs which are being used, especially first the prokinetic drugs and the H2 receptor antagonists and the proton pump inhibitors. And if you take each class like prokinetic drugs, so they actually increases this motility. So they increases the gastroparesis. So they addresses the issue of delayed gastric emptying, and they also sometimes addresses the issue of the distal end of the esophageal motility disorders. So by pushing the food distally, so it reduces the proximal regurgitation. So mainly three drugs were actually approved by the FDA. One is the bethanocol, which is an anticholinergic. Then we have got a very famous metaclopramide, which is a dopamine antagonist, and we have got a 5-HT receptor agonist, that is a cisapride. So cisapride actually was withdrawn from the market due to its cardiotoxicity, a very notorious drug in causing QT prolongation. So nowadays we've got other varieties of these prides. So all these are available in the markets. So these are basically used to increase the gastric motility. And the next,
what about domperidone?
Yeah, the domperidone is also a dopamine antagonist, but the difference between the metaclopramide and domperidone is metaclopramide crosses blood-brain barrier, whereas domperidone does not cross blood-brain barrier. So metaclopramide is exposed to the dopamine antagonism in the central nervous system also. So patient may have extrapyramidal symptoms. The patient may have tremors, patient may have Parkinsonism symptoms. So, but domperidone is devoid of these particular side effects. Yeah. Whereas if you see the efficacy of these two, the metaclopramide is better in preventing the reflux than the domperidone.
So, is it safe to use metaclopramide routinely?
See, as far as safety is concerned, yeah, it is definitely safe, but you need to advise your patients regarding some of the side effects, especially the sedation which is going to have and the extrapyramidal
EPS
symptoms.
Yeah. Are they self-limiting? Once we stop
sometimes they're self-limiting, but I have seen worsening symptoms, especially if the patient is on the coexisting dopamine antagonist, or if the patient is having a pre-existing Parkinsonism also. Because especially in old age, 60-year-old people, if you give metaclopramide, they may have a severe tardive dyskinesias. They sometimes have a dystonias. I have seen patients coming with a dystonias, which are very disturbing to the patient. So these can be very important in addressing the issues.
The MCQ commonly asked or in the Viva, that is, which antibiotic has got this prokinetic property?
Yeah, the erythromycin, all these drugs have got definitely, but azithromycin is a one drug which underwent a study in a patient of recurrent ILDs. So as I told you, the recurrent pulmonary infections and the recurrent ILDs are can be due to GERD, the unexplained GERD or undiagnosed GERD. The azithromycin was one drug which was proven efficacy in delaying or in reducing the refluxes in this, but especially the motilin agonist, the erythromycin, it's been commonly asked as an entrance question. The major side effect of erythromycin is diarrhea. One of the which of these is a motilin agonist, which has been asked directly in the entrance question also. But along with the erythromycin, even the azithromycin also has a similar kind of mechanism of action. And there are
you're telling about the prokinetics. So next other two groups.
Yeah, other two groups are the acid suppression therapy. The main acid suppression therapy, we know we have got the H2 receptor antagonist and we have got the proton pump inhibitors. Among these two, definitely the PPI are very efficacious in preventing the acid suppression, because the duration of the acid suppression is very long, as with the proton pump inhibitors. The acid suppression is being achieved for the approximately 16 to 14 hours, 15 to 16 hours, sometimes 20 hours in some medications. Whereas with the H2 receptor antagonist, the efficacy is a little bit lesser compared to the PPIs. And in studies also, the healing of erosions of the esophagus was seen much better with the proton pump inhibitors than compared to the H2 receptor antagonist. But nowadays, in the era of PPI, we know that in the 2020, the total business by PPI was, I think, more than 90 billion worldwide. In this era of proton pump inhibitors,
that 80 billion would be over the counter medication.
Yeah, maybe. But this H2 receptor antagonists nowadays are cracking the thing, because, as I told you, the nocturnal acid excursions are very, very common and very important in disease, and very important to prevent also. As I told you, the proton pump inhibitors, when we give in the early morning, the acid suppression is being inhibited for the next 14 to 18 hours. Whereas as the night comes, the acid excretions do occur. Exactly. So nowadays there is a tendency to use H2 receptor antagonist in the night time before food and early morning PPI. So the combination of a PPI and a H2 receptor antagonist is going to achieve a better response to the erosions.
I have 1 to 3 doubts as well. There are the controversies as well. Okay, which PPI is better, like pantoprazole, omeprazole, or newer lansoprazole or anything? That's the first question.
Okay.
And second thing, how about giving high doses like 80 pantoprazole of 80 mg also? Okay. And second, thirdly, whether pantoprazole along with this sucralfate, can it be given together?
Okay, the first question you asked is the type of the PPI. See, there are actually head-to-head studies which are available, but none of them have proven the efficacy of one PPI better than the other PPI. All the PPIs are equal, but the patient selection is very, very important, because we know that the metabolism of PPIs, especially some PPIs, which has been through the CYP2C19, which is the major cytochrome P450, which has been involved in the metabolism of this. So, especially the omeprazole. So, when we give other drugs which are metabolized through the same enzyme, one important correlation is with the clopidogrel. The relation between the omeprazole and clopidogrel has been very, very important, because omeprazole and the clopidogrel have been metabolizing through the same enzyme. So there is a competition between these two. So whenever we give the omeprazole along with the clopidogrel, the antiplatelet efficacy of the clopidogrel is reduced. So that's why there has been a lot of issues regarding the omeprazole. And the drugs which are not being metabolized through the CYP2C19 are the elaprazole and the lansoprazole only. All the other drugs are metabolized by the same enzyme. So apart from this drug-to-drug interaction, there is no saying that one particular PPI is better than the other PPI. You can use all the things, and dosing should be known. The dose should be standard dose. We should not use a low dose PPI. I will be giving you the doses. For the omeprazole and the esomeprazole, it is 20 mg per day.
20 mg.
For the rabeprazole, it is 20 mg. For the lansoprazole and the dexlansoprazole, it is 30 mg per day. And for the pantoprazole, it is 40 mg per day. So these are standard doses. There is a tendency to use a higher dose of PPI in a particular setting called refractory GERD. There is a particular terminology called refractory GERD. It means the persistence of symptoms even after a standard course of acid suppression therapy. This standard course means 4 to 8 weeks. 4 to 8 weeks of this standard suppression therapy is definitely not used for the GERD. I have seen any doctor writing 8 weeks prescription of this. So many of the times they will be writing 3 tablets, 4 tablets, or on need basis. So this is not going to achieve the desired thing in case of GERD. So after 8 weeks, even if you're not responding, the patient can have an increased dose of particular PPI, but it is better to use 40 mg BD rather than 80 mg per day. That is a very important thing when you're using higher dose of PPI. And even you can switch the classes if the refractory GERD is there. But one particular GERD is not more good than the other PPI.
But many patients I have seen, they're addicted to this PPI. Once PPI is for like, they get a lot of relief in that. So without asking doctor's advice, they'll be keep eating that to get the relief. So does it got any adverse effects? So long-term PPI injection has got shown to cause gastric.
Definitely. The safety of this PPIs have been lot of interest in recent nowadays in the research field. So one of the very important are the local side effects, the GI side effects. So we know that it suppresses the acid therapy. So there was a thinking that it might cause achlorhydria, but achlorhydria was not identified actually. But in turn, it caused gastric polyps, the fundal polyps, due to the proliferation of these parietal cells. So the polyps have been very, very common. And since it suppresses the acidity, we know that gastric acidity is a part of innate immunity. Many of the bacteria tend to get lysed due to their non-tolerance to the acidity. So patients get exposed to a lot of bacteria, especially the Clostridium difficile and the patient of community-acquired pneumonia bacteria like the pneumococcal, the H. influenza, the community-acquired bacterial pneumonias have increased due to the constant PPI use, the Clostridium difficile, and the evidence of inflammatory bowel disease has also increased secondary to the chronic PPI use. And the very interesting is the this gastric acidity and parietal cell function is very, very important to absorb many of the interesting and important contents like the vitamin B12, iron, calcium, magnesium, very, very important. So the chronic PPI use can cause the vitamin B12 deficiency, it can cause iron deficiency, it can cause hypomagnesemia. Even the hypomagnesemia progressing into ventricular arrhythmia in a patient who is on chronic PPI therapy is a lot of articles are available in the internet. So the safety of the PPI has been a question mark. And the very
Have you
unexplained
seen
thing
any
is that
anaphylaxis? I've seen 1 or 2 cases of anaphylaxis of to pantoprazole,
for oral or for IV?
IV pantoprazole.
Okay, okay. I have not seen anaphylaxis, but I have seen a minor reactions to the IV pantoprazole. I have never seen a oral PPIs producing an anaphylaxis. IV, yeah, I have seen some amount of rashes, etc., but not an anaphylaxis kind of thing.
So what about this combination of? You didn't tell that about the
Yeah,
supra.
as I told you recently, in the era of PPI, the H2 receptor antagonists are gaining the confidence, especially the particular preparation of Rantac 300 mg before bedtime food, along with the early morning PPI, is very, very important in preventing the nocturnal excursions. And there are studies going on also to prove the efficacy, but the whatever the small studies which are available have shown the increased efficacy, increased healing of the esophageal ulcers with the combination of morning PPI and the nighttime H2 receptor antagonists as a combination. And there are some drugs available also, like very uncommonly used drugs which are available for the GERD. Like we have got the GABA B receptor antagonists. We know that this particular receptor is being situated in the lower end of esophageal sphincter, which is being highly innervated through the vagal nerve. One of the very common drug is Baclofen, which we commonly use for the intractable hiccups, can be used for the GERD. The only problem with the Baclofen is the side effect, the sedation, and sometimes vomiting. There are other new drugs which are available along with this class of section, that is called as Libogabron. The Libogabron is available, and there is one prodrug of this Baclofen, that is Baclofen, Placarbil, some drug which was available. Studies are definitely going on, and the newer class of acid suppression therapy are being into the market, like potassium competitive inhibitors like Omeprazole, which has been recently approved drug for the peptic ulcer disease, which can be used for the patient who is not responding to the standard dose of PPI therapy. This is a PG level discussion or the DM level discussion. Yes, definitely it is available. There are other drugs also, like TRPV1. TRPV1 is a very interesting thing. All the UG students should be read about this particular receptor. It's a very important pain receptor, the vanilloid kind of receptor, important in both diabetic neuropathy and many other diseases. We use a caspacin. The caspacin is the only locally approved treatment for the diabetic neuropathy, which is a TRPV1 agonist. So the TRPV1 antagonists are being in research for the GERD, which might be the future. In next 10 years, we may have a TRPV1 antagonist as a treatment of GERD.
So what about the endoscopic treatments after the medical treatment line of treatment? As a second line treatment, we do have some endoscopic treatments. So you physicians,
in the last decade, after the medical treatment, the patient used to directly shift to the surgical treatment. Nowadays, we have got a bridge between the medical therapy and surgical therapy, that is an endoscopic management. So there are many types of endoscopic treatments are available. The one very important and very famous is the TIF, that is called a transoral incisionless fundoplication. The concept is same, similar to the fundoplication. You create a pseudo esophageal sphincter, wrap around. So, but it is done through the endoscopy, and there are other techniques, like there is a techniques by endoscopic suturing techniques which have been available, and there have been radio frequency ablations through the endoscopy, in which the radio frequency shocks are given to the some 6 to 7 areas in the distal end of esophagus, which actually makes this lower esophageal sphincter contracted and very strong in reducing this one. Although efficacy has been achieved through these endoscopies, but it needs a very high technical knowledge and the availability of the trained person also. Yeah, I think regarding the surgical management, there is no better person other than you to discuss the surgical management of GERD.
There are some indications, like Dr. already Raj mentioned. First line of treatment for GERD is always medical treatment. So, and when do we say exactly the medical treatment is failed, and since it's not responding, how long do we have to wait?
So 4 to 8 weeks is a definite criteria for a refractory GERD. But it is there that when a patient, you label him as refractory GERD, you need to address a lot of questions, whether you have used PPI in the right duration, whether the compliance was good or not, whether was there any metabolism defect, Was there any lifestyle abnormality which has been going? After addressing all these issues, if the patient is not responding, then the surgical management is advised.
So, okay, once the medical line of treatment is done, is not responding or having severe symptoms, continues to have severe symptoms, that's the one first indication for surgery. Okay, patient is not responding to medical treatment. Second thing, he have very severe symptoms which cannot be tolerated. Okay. Thirdly, some associated conditions like we discussed in the beginning, like hiatus hernia, okay, or some Barrett's esophagus or stricture. Okay, and thirdly, that is okay. These are the main indication wherein we go for surgical management. In surgical management, we have many varieties of anti-reflux surgeries which were devised starting from 1950s. We have a lot of modifications done in that anti-reflux surgeries. So mainly nowadays, what we do as a gold standard procedure is laparoscopic Nissen's fundoplication. That is, fundoplication means fundus. The stomach, the fundus of the stomach is wrapped around the lower esophageal sphincter to make it to increase the tone or the tone of the lower esophageal sphincter. Okay, that is the procedure. So how it is done is, let me briefly tell about the anatomy, the surgical anatomy also, and the procedure as well, because it's asked in Viva, the procedure itself. And so firstly, both either in the open or the in the laparoscopic technique, what we do is first mobilize the stomach and the esophagus. Okay, lower esophagus and stomach has to be mobilized to make it to bring it lower down, and the esophagus, and to make the fundus move around the esophagus. So how do we do that? There is also the peripheral condensation of the peritoneum. It's called the esophageal ligament that we mobilize, that we cut and mobilize it first, and then that hepatogastric ligament, that also we will cut, and so that the gastric fundus is mobilized. And thirdly, we during using harmonic cautery, we cauterize all the short gastric arteries on the lateral aspect. Short gastric arteries are all cauterized, and so entire stomach is mobilized now. After mobilizing stomach and the lower end of the esophagus, secondly, we have to look at the crura, both the right and left cruras. Okay, that sometimes we may have to mobilize the intra-abdominal part of the esophagus. So that time, this dissection of the crura are very important. So we dissect the crura, right and left diaphragmatic crurae, and then we get the adequate length of the esophagus inside the minimum of 3 to 4 centimeter minimum of intra-abdominal part is required. So, and it is inversely proportional. More the length inside the abdomen, less the chance of reflux. So that's the one point we should, one of the principles of anti-reflux surgeries. So after adequate mobilization of the lower end of the esophagus and the gastric fundus, next thing is what we do is take consider this is a esophagus and this is the stomach. The fundus of the stomach, this is the fundus of the stomach. We take a wrap around the esophagus. We make all around the esophagus. We clear it. Okay. Now this is the esophagus, is the stomach possibly. So the fundus is wrapped around the esophagus like this. Posterior. This is the anterior esophagus. The stomach will be usually on the left side like this. So from the posteriorly, the fundus is wrapped around the esophagus like this. Okay. And we put stitches in the anterior here with my finger. This where it's shown. Three stitches put like this. So this is called Nissen's 360-degree posterior fundoplication. Okay. So ideally, what should be done is Nissen's floppy fundoplication. What do you mean by floppy fundoplication? Is it should not be very tight. This fundoplication should not be very tight. It should be floppy, little loose, so that they won't have any dysphagia. One of the most common side effects after these anti-reflux surgeries, this not able to pass the this thing out, not able to belch, not able to pass out the air from the stomach because of it's too tight of the wrap. So to avoid this, and the second most common side effect of this surgery is dysphagia. To avoid these two complications, what we do is floppy Nissen's fundoplications. We keep the wrap little loose. How do we know it loose or tight? If it's laparoscopic surgery, we take one 5 mm grasper and we open it inside the wrap. If it's freely, if it is we open, then we say it's adequate. Even in the open, we put our fingers through the wrap. If it's freely going inside the wrap, then we say it is adequately floppy. Okay. So this is the floppy Nissen's fundoplication, 360-degree, and from the posterior aspect of the stomach. This is the gold standard one. But definitely, any surgery has got some complications. Like I said, if it's too tight, it can cause gas bloating, abdominal gastric bloating syndrome, or also it can cause dysphagia and other things. Secondly, one of the modifications of this is toppets. Toppets, instead of full 360-degree, what he suggested was only 180 degrees more than enough. Only posterior 180-degree wrap is made so that the anterior part will be can expand, and that can prevent this gas bloating syndrome. It's one of the modifications by toppets. And the third most commonly done nowadays, although not done, but commonly we should be knowing in the exam point of view, is Dors fundoplication. It is from anterior, only anterior fundoplication, that is Dors fundoplication. And from posteriorly, we should be knowing about toppets fundoplication, that is 180-degree posterior fundoplication, and the Nissen's 360-degree posterior fundoplications. These are the commonly done anti-reflux surgeries. And along with the role of surgeries, also in case of managing the complications of GERD.
Like what are the actually main complications of the GERD? Majorly, they are surgical actually.
Yeah, GERD can cause severe esophagitis. Like you said already, grade 3 and grade 4 LA Los Angeles classification. They are the indications for again surgery. We can do either resection anastomosis. We can severely esophageal or having Barrett's ulcers. That area can be resected, and the remaining part can be anastomosed. Okay, if the length is too much, we can get some ileal conduits or some other conduits can be used to make up the length. Okay, and thirdly, we have another complication is stricture, esophageal stricture. So in the first stage, we try with endoscopic dilatations, Vogie dilatations, but this has to be done very frequently. Okay, so as a permanent solution, we again do the resection anastomosis of the stricture segment.
You can have an endoscopic triamcinolone injection in the intralesional.
Yeah, that's a Botox injection. A Botox injection can be given. Okay, our second thing, the stents can be, if as a palliative measures, we can also give the keep the stents. Okay, SEMS, self-expandable metallic stents are available that can be kept, and Vogie dilatations can be done. Best one is with young patients having strictures. Okay, always better to go for surgical resection and anastomosis of the same. And of course, as we know, this esophagitis can lead on to metaplasia and dysplasia, Barrett's. It should be on regular follow-up. This Barrett's esophagus, it's pre-malignant condition. So a high chance of 10% chance of getting into adenocarcinoma of the esophagus. Adenocarcinoma, many patients comes to us with adenocarcinoma. In that again, there is a role of esophagectomy and then the anastomosis of the proximal and distal ends. So these are the roles of surgery in case of GERD and managing its complications.
Being the upper GI bleed, which I want to add on this. Yeah. Another complication, a very important complication. It can be sometimes massive, or it can be the minor, causing frequent hematomesis, or the maligna, causing unexplained iron deficiency also. Yeah.
So all the complications have been dealt, I think.
Yeah, all the major complications have been involved.
Coming to once again, I want to the role of prevention of GERD. I want to stress already. Dr. Rajas told about it, but I to all my patients, I always, before giving any medicines or going for surgeries, I always like he also mentioned, this is a lifetime process. This lifestyle and dietary modifications, medicine or surgery is a one-time process, but whereas a lifestyle and dietary is the lifetime process. So we have to again stress on these aspects of the management as well to avoid the recurrences. So one thing, first and foremost, Raj, to our consensus, first we will suggest our patients to reduce the overweight if they're obese. Correct? That's the first one you indicated. Second one is
head end elevation.
head end elevation. Okay, that again acts as a S2 receptor blocker only. It's in some studies shows. Okay, so head end elevation. You ask the patients to keep that cot, the two bricks under the cots or something like that, so that the head end is elevated, so that reflux or regurgitation or reflux cannot occur so easily. Okay,
Yes,
it's anti-gravity.
Gravity do its job.
Yeah, that's the second thing. And thirdly, eating the nighttime food should be minimum 2 to 3 hours prior to the sleeping time. That's one, or many of our standard books do mention even now that about the more than 3 hours gap between, and the food should be not sumptuous meal at the night, only small chunks in a repeated like doses you can have, and mainly better to avoid, although it is proved or not, I don't know, still it's better to avoid fatty and oily and spicy foods or irritants to the citrus foods also, and also caffeine and nicotine contents like coffee, tea, chocolates, all those things, and carbonated drinks. Very importantly, carbonated drinks. These are better to be avoided, not just for GERD, for all most of the medical conditions for that matter. So, anything you want to add on to this?
Alcohol.
Yeah, of course. Yeah, you already mentioned the role of it. It's a direct mucosal toxin which can cause damage to the mucosa as well as the sphincter. So alcohol and smoking both has to be avoided in this case. So with that, any other doubts?
There are questions.
We can, some doubts are there. I'll just read it out for you. Why it is said that PPI should be taken half an hour before taking food, but actually PPIs act only after absorption into blood?
Okay, see, this is because we know the mechanism of PPI. It is the inhibition of this parietal cells. So we want this drug to be active when the parietal cells are maximally active. So we should know when the parietal cells are maximally active. The parietal cells are maximally active after the consumption of food till the next 90 minutes. So by that time, the patient should be ready to inhibit the parietal cell function. So that's why it is ideally to be taken before the first meal of the day. That is where the first highest parietal cell function is, after the first meal of the day. So that's why it is preferably, or it should be taken before 30 minutes of the first meal of the day.
And next, one more question, good question he has asked. Just a second. Dr. Narasimha has asked you, why PPI is drug of choice in GERD, although floppy lower esophageal sphincter is the main pathophysiology in GERD. Actually, dopamine antagonist should be the DOC.
Mainly because of the toxicity, and at least we cannot, if we cannot improve the tone of the lower esophageal sphincter, at least let's reduce the acidity. And we know that this is an evidence-based medicine we are practicing nowadays. So we go through the evidence. So the evidence of this proton pump inhibitors in improving the esophagitis, and both the erosive and non-erosive esophagitis, and the symptom benefit. When you compare the PPIs with the dopamine antagonists or the GABA antagonists, whatever you say, so the statistical significance of this PPI was much more better compared to the other drugs, and achieving the efficacy, reducing the symptoms, and also improving the erosions and the esophagitis. So that's why the PPIs have been the drug of choice till now. We don't know what is coming for us in the next 10 years, but till now, we may have a dopamine antagonist in the next coming 10 years, which might be much better than PPIs. But for now, the PPIs, as a part of evidence-based medicine, are the drug of choice in GERD.